Good morning. I'd like to welcome you to the last of the press conferences taking place here at the 2014 Quadi annual meeting. Today's press conference will unveil and discuss the Quadi's list of 5 more things physicians and patients should question, which is part of the ABIM Foundation's Choosing Wisely initiative. This is actually the second Quadi list of evidence-based recommendations that are designed to help patients and physicians start conversations and make wise choices regarding the diagnosis and treatment of allergy, asthma, and immunologic diseases. I'm going to quickly introduce our speakers that are here today that will talk about the list items. And again, I would ask that you hold all questions until the start of the Q&A portion has been announced. And today we have with us Dr. Linda Cox, who is Quadi President for a few more hours. Then we also have Dr. Ted Freeman, who is on the Quadi board. We also have Dr. John Oppenheimer, and we also have Dr. David Lang, who is also on the Quadi board. And at this point, I would like to turn things over to Dr. Cox.
Thank you, and thank you for attending. I would hope all of you are a bit aware of the Choosing Wisely campaign, which I think rolled out about 2 years ago. And I'm proud that the Academy was one of the original 9 organizations involved in the campaign. And we actually attended that big press conference they had in the press room in Washington, D.C. And the intent of the Choosing Wisely campaign is recognizing that evidence shows that much of care delivered in America is unnecessary. And the intent was to bring the national groups together to identify a list of tests, procedures, or medications that are commonly prescribed but maybe not always necessary. And it's really about starting a conversation between the patients and the physicians. And our list of Choosing Wisely, which were developed with the first campaign, which is now published as a book that you can get through the ABIM Foundation. Our 5 things are actually on the first page of this document. And I'm a practicing clinician. I have to say I've found several of these, if not all of these, useful in my practice, particularly the one regarding routine allergy testing. When patients come to me and maybe have been tested with an unproven method, or they want to have some type of testing done, and I'm trying to explain to them that in this particular condition, allergies are not causing it. So it helps me in trying to explain to patients, because these documents are directed at professionals, but there's also a lay organization translation. So there's an easy reader version of these documents that you can get on the foundation website. So the Academy decided this past summer that we would continue with the second effort because the success of the first effort apparently attracted, I've lost count, but there are well over close to 30 other organizations that have joined on with the second stage of the campaign and are bringing their things that might need to be scrutinized or part of a conversation between patients and physicians. And we decided Ted Freeman, because he's an outstanding hard worker who thinks critically and balances pros and cons, would be an excellent person to chair it and take it to completion. And he did. And I'm going to turn it over to him to discuss our second stage.
Linda, thank you. I was just ecstatic when Linda asked me last year to chair a committee to look at if we should participate in a second round of Choosing Wisely, because I found the program to be an excellent program and generated a lot of conversation with my colleagues and other patients. So I was really very happy to be involved with this. What we did initially, I took a rather small committee because our first charge was, should we participate in a second round? And I involved Dr. Mike Clayton, who's on the board of directors, and Dr. David Houston, who was involved with the first round of Choosing Wisely. And our first question was, should we participate again? And we said, oh, there's no question. That was a fairly easy meeting that we should participate again. And we made a few proposals. When we involved Linda and Tom Casale, made some more proposals. Then we went out to all of our membership through our intersection leadership and said, what protocol, what items should we consider in the second round of Choosing Wisely? What things should we do? And we got half a dozen, 10 different things that we should consider, and eventually the board of directors narrowed it down to 5 things. Okay, and that's the 5 you're going to hear about here in just a moment. What I want to mention is that each of these has a potential for a huge impact on our patients and on our healthcare resources, and that all of these items fall within our purview. Okay, and all of these items are evidence-based, and they're meant for our patients, and they're meant for the whole gamut of our physicians, whether you're in a small practice like Linda or I, or in a big academic practice like Dave at the Cleveland Clinic. So what we were going to do next, with Linda's permission, is go over each of the new items for you. Okay? And the first item is actually one I was going to go over with you. And that is, don't rely on antihistamines as first-line treatment in severe allergic reactions. What you need to know is a severe allergic reaction is anaphylaxis. Anaphylaxis is a multi-organ system syndrome. Okay? It often presents initially with cutaneous findings, hives or swelling or flushing. But it involves other organ systems, in particular the cardiopulmonary system, where people can be short of breath and wheeze and have chest tightness, or the heart, where you can get dysrhythmias and get low blood pressure, and people die from these other organ system involvements. Antihistamines only treat cutaneous findings. They do not treat the life-threatening events that happen in a severe allergic reaction. Consequently, epinephrine is the therapy of choice in severe allergic reactions, not antihistamines. To highlight this point, that people die from anaphylaxis, severe allergic reactions, there's been several high-profile deaths that have occurred in the United States in the last couple of years in children with food and insect sting allergies who did not receive epinephrine when they were anaphylaxing, and they died. This resulted in Congress passing a bill last year and President Obama signing a bill that encourages the states to provide legislation that says it's okay to have unassigned epinephrine in the schools for people that are anaphylaxing. That highlights this item. Don't rely on antihistamines as a first-line treatment in severe allergic reactions. Now I'd like to pass it to John to talk about the second item.
So our second item, which is entitled Don't Perform Food IG Testing Without a History Consistent with Potential IG-Mediated Food Allergy, is a really telling one. As you know, there are a lot of false positive reactions. As a matter of fact, a beautiful expose on this was out in the Wall Street Journal about 2 or 3 years ago. And it reminds me that just because a test exists doesn't mean that it's a useful test. The tests we have available for food allergy, whether it be blood or skin tests, are really confirmatory tools, not screening tools. What do I mean by that? There's no reliable test that tells if a little girl or boy at birth is allergic to peanut or milk or egg. We only learn that when they eat it. If there was such a test when they were born, we would get a little vial of their blood at birth, wouldn't we? And so what this test really, what this statement does is reinforces the fact that our present tools available for food allergy really are corroboratory. So what I mean by that is if somebody comes with a history of I've eaten a peanut and I've had, as you point out, multi-system involvement, difficulty breathing, diarrhea or vomiting, and it seems to be temporally related to the peanut, their first ingestion or second ingestion, by performing a skin or blood test, specifically in this case a blood test, we can confirm the story. That's a different story than obtaining a plethora of bloods, which are available, by the way, to screen to see if somebody has quote-unquote food allergy. So again, I would reinforce, we don't want to perform food IG testing without a history consistent with potential allergy. Otherwise, we're going to have too high a false positive rate. And by the way, it's about greater than 50%. Pretty sobering. I think you're next.
Yes. I'm going to read this off and then I will explain it. Don't routinely order low or isoosmolar radiocontrast media or pre-treat with corticosteroids and antihistamines for patients with a history of seafood allergy who require radiocontrast media. So first I'm going to describe radiocontrast media and radiocontrast media reactions. So this is X-ray dye, basically. When you go in for a CAT scan, you get an infusion of contrast material. And this is done frequently. It's one of the most prescribed drugs, if you will, although in this case for diagnostic purposes, one of the most frequently prescribed drugs in North America and in the world. So there are different types of adverse reactions that can occur to contrast media. Sometimes people get nauseous, sometimes it affects your kidney function. But here we're talking about contrast media reactions that are in the category of what Dr. Freeman described as anaphylaxis. So this is a reaction that entails itching, hives, sensation of throat constriction, difficulty breathing, drop in blood pressure. Fatalities can occur. These reactions can be very serious. The reaction rate is about 1 to 2% for contrast media reactions that are in the category of anaphylaxis, and serious reactions are about 0.1% or 1 in 1,000. Now, there are certain groups that are at elevated risk for contrast media reactions. One is people who are prior reactors, who've had similar reactions in the past. With re-exposure to contrast media, their reaction rate is elevated compared to the general population in a range of about 17 to 35%. Now, these individuals are candidates for risk reduction measures. The risk reduction measures include two things. First of all, pre-treating with medications. That's antihistamines and steroids prior to the contrast infusion, and the use of what's called an iso or low osmolar contrast media. So now the reason that people have these reactions is really unrelated to allergy per se, although in most cases the reaction mimics an allergic reaction or anaphylaxis. The reactions occur because of the physicochemical properties of the media, of the X-ray dye itself. Now, if studies 2 to 3 decades ago showed that if we pre-treat with antihistamine and steroids, we can reduce that elevated reaction rate in prior reactors from 17 to 35% down to a range of 5 to 14%, and the reactions tend to be mild in degree. If you couple that with administration of a newer, more expensive, although the disparity has come down more recently, what's called a lower isosmolar contrast material, which has the physical-chemical properties such that it's less likely to cause reaction. If you couple that with pretreatment, the reaction rate then is less than 1%. So it significantly reduces but doesn't eliminate the risk of reaction. So prior reactors, those individuals who've had a reaction consistent with what I've described, are candidates for pretreatment and use of a low osmolar contrast agent. Other types of patients who are at elevated risk for these reactions include people with asthma, people with heart disease, people taking medications called beta blockers. Now, there is a misconception that individuals who have real or suspected seafood allergy are also at elevated risk of these reactions. That's not true. There is no convincing evidence in the world's medical literature which implies that that's the case. So such patients are not candidates for pretreatment. A phone survey showed that about 3 to 3.5% of the U.S. population self-declare themselves as having seafood allergy. According to the 2013 population estimate for the United States, that's about 10.5 million Americans. So that's a lot of people who would unnecessarily receive these pre-treatment regimens that include antihistamine, steroids, and exposure to the isosmolar or low osmolar contrast material. I should add that when individuals have such reaction, they should not be told automatically, because they've had a reaction such as this, that they should regard themselves as being allergic to seafood. Parenthetically, I would add that just as these reactions have nothing to do with seafood, they also have nothing to do with iodine. Nobody's allergic to iodine. There's iodine in table salt. So again, because someone has a history of seafood allergy, they should not routinely receive this pretreatment. However, the individuals who are in these subgroups that I mentioned are candidates for risk reduction measures.
David, thank you. And John, thanks for the discussion that you did on the food allergy. The fourth item I'm going to cover as well, and this item is don't routinely avoid influenza vaccination in egg allergic patients. As most of you probably know, most of our flu vaccines are actually grown in an egg culture. And so there's always been a concern that patients that have egg allergy, if they get influenza vaccine, could have a reaction to the vaccine. Okay. This doesn't happen. Let me highlight that for you with just a couple of numbers. Okay. I went to the CDC website. This flu season, starting 29 September 2013 to as of 22 February 2014, we've had over 40,000 cases of flu in the United States. And unfortunately, we've had 61 pediatric deaths from influenza. 27 published studies, 4,172 patients with egg allergy. 513 of those with severe egg allergy. So if you feed these patients eggs, they have significant symptoms. Those 4,000 patients received 4,729 doses of influenza vaccine. How many of them had reactions? Answer, 0. Clearly, if you match 61 deaths versus 0 reactions, this is an important item in choosing wisely. Don't routinely avoid influenza vaccine in egg allergic patients. I'm going to ask Linda to talk about the fifth item.
Thank you. The fifth item is don't overuse non-beta-lactam antibiotics in patients with a history of penicillin allergy without an appropriate evaluation. And what that means is patients who walk in and say they have a history of penicillin allergy don't assume that they really do. Because there's been studies over time, many studies over time, that have shown that only about 10% of people who report having a history of penicillin allergy actually have penicillin allergy if you test them. And now we have available to us is an FDA licensed extract for penicillin testing. Studies have shown that if you still have the label of penicillin allergy and you're hospitalized, you're going to be treated with more expensive antibiotics and potentially antibiotics with more side effects. And so having patients evaluated for penicillin allergy who have at least a very vague history, because many of the patients I see, it was sometime when I was a child, my mother told me never to take penicillin. Stamped. All their life they're going to be stamped with penicillin allergy. Whereas if we just had them evaluated, skin tested, and appropriate protocol, we could open up that avenue or that large menu of antibiotics that are available in the penicillin M-related family, because actually in our guidelines it recommends that if you are penicillin allergic, you should not receive cephalosporins, which is Keflex, etc., unless you're evaluated. There's an algorithm that we have. So this is encouraging practitioners and patients to consider the diagnosis of penicillin allergy scrutinize it and maybe consider being evaluated. I would also say that there is some evidence from one study that showed that once patients were evaluated and proved not to be penicillin allergic, it somehow haunted them in their chart. So it's imperative that the allergist immunologist who evaluates the patient determines they're not allergic, make sure that that's made known to their medical records so that those medications, those penicillin products can be prescribed to them. And I think that concludes the 5 things. I just want to bring up one thing, and it's related to the previous 5 things, because it's now as of now out of embargo. David Houston, who is with the ABIM Foundation, but also a previous board member of this organization, was really the one who pushed us, spearheaded this effort in the beginning. And David asked me, he was invited to write an article for the JAMA series called Less is More. It's called Less is More. It's JAMA, Journal of American Medical Association. And they wanted an article on one of our first published items. And David and I chose don't perform unproven diagnostic tests such as immunoglobulin G testing or an indiscriminate battery of immunoglobulin E test in the evaluation of allergy, which is very similar to one of the other items. And so David and I developed a patient vignette, which was actually based on one of the patients, or a hybrid of patients I saw in my practice. And it was a child with ADD, attention deficit disorder, coming in with a battery of food tests. The mother had been kind of talked into having a child evaluated with food IgG testing because they said that this would help treat this child's ADD. And she had gone through this elimination diet based on this long list of foods. And IgG is not the antibody that causes allergy, and allergy doesn't cause ADD. But she had all this angst because she had put the child through this elimination diet. He didn't get any better, and his behavior actually got worse because he wasn't eating the foods that he likes. So she had kind of a guilt, is it okay? Can I introduce these foods? And we had a lengthy discussion, but fortunately I had this to show her, this first thing, and I think that helped her explain that test did not really relate or was not helpful in the treatment of that child, and hopefully directed her to more appropriate treatment. So I will stop, and I think we're open for questions.
At this point, we'll open it up for questions.
Mary Tackett from American Journal of English Care. For any of you, either from the first list or like if anyone's been able to quantify some savings from one or any of the items, or if there's any projected savings from this current list.
I don't know. I don't know that we have benchmarks on those yet. It's a little hard. But I would say one of the big dollar ones was don't order sinus CTs or indiscriminately prescribe antibiotics for uncomplicated acute rhinosinusitis. Most sinusitis is viral in the beginning. And there's a temptation for physicians to treat when patients come to the office and treat with antibiotics. But there is a lot of evidence that these resolve without any intervention. There's systematic reviews that have shown that most will resolve with or without antibiotics. So it is recommended by both the ENT, adult sinusitis guidelines, to have watchful waiting. If the patient's not immune deficient or has any other unusual medical conditions, 7 days of observation is appropriate, providing they don't have a high fever or other. Sinusitis, maybe one of you could correct me, it's like one of the top 5 reasons for antibiotic prescriptions.
Yes, it's
And
also a frequent reason for medical visits.
Medical visits. So you can imagine if it's the top 5 and only 1% of those should get antibiotics, or maybe a little higher, because some of these patients have waited, but it's probably not that much
But a
off.
consistent theme throughout all of these is that just because a test exists doesn't make it useful. And I think beyond just the expense of the test, you're putting people through potentially needless rigor. An example would be food, avoiding a food for years for no reason, or taking an antibiotic and having potential deleterious effects. So I think it's really hard to put a numeric value on this because there's a lot of downstream potential sequelae.
Yeah, I think what we're saying is similar to what the U.S. Public Health Service pointed out with regards to routine mammography screening, where the numbers have been worked out much more clearly than the kinds of diagnostic interventions that we're discussing here, in terms of not only unnecessary cost, but also identifying individuals with test abnormalities in whom it's an incidental finding. And in other words, an abnormal test result is not tantamount to making a diagnosis. It just means you have an abnormal laboratory test result. And it's a problem if these tests are ordered routinely without a history that's supportive for ordering the test.
I'll chime in, and again, I don't have any specific economic data, but some of the measures that look at utilizing tests, lab tests and radiologic tests, are clearly overused, and if we don't do those, we're going to be saving economically. The issue in the first set of practice parameter, or choosing wisely, was that we had one of the issues was don't order CAT scans in sinusitis. Don't initially order a CAT scan. This was important enough that I'm pretty sure, if I remember correctly, the otolaryngologist had almost the same item in their series of choosing wisely. And the food allergy testing that John talked about, I think, was also in pediatrics choosing wisely. And so these are all important items that have a lot of value, and the value is that we're doing the right thing by not doing extra testing.
Can I also, the other important thing, I know we're all thinking healthcare dollar costs, et cetera, but I mean really quality of patients' life and what happens to patients, and what John pointed out, people avoiding these foods for 20 years or 10 years because somebody did a battery of testing when they were coming in with a disease that has nothing to do with allergy. And that has a lot of impact on patients' lives. And I would like to point out number 5 of our old, which is don't diagnose or manage asthma without spirometry. And I know in practice, I do see a fair number of patients who have prescribed fairly high-level asthma treatment, what we would call step 3 or step 4 asthma treatment, dual inhalers, that have never properly been evaluated for asthma and turns out didn't have it. But they might go along, these inhalers aren't cheap, for a bit. I mean, I've had people with histories of about a year or so before they kind of got in and got appropriate evaluation, and it was determined that it was really the cough was coming from sinus or something else. So I think it's really important to stress the appropriateness of diagnosis and treatment, as well as the healthcare savings. But I mean, it's about what's appropriate for the patient and best for the patient.
Yes, and I would point out also from our first list that one of the recommendations is not to routinely do extensive testing in patients with chronic urticaria, that is, individuals with hives or swelling that continues longer than 6 weeks. And in addition to the issue of cost and the potential harm done to patients in terms of giving them a false diagnosis, in other words, they're avoiding a food that they suspect they're allergic to when really they're not. In addition to that, the issue of ordering a test or any diagnostic or therapeutic intervention with which we intervene is, does it lead to improved patient care outcomes? And with regards to ordering extensive testing for patients with chronic urticaria, in the overwhelming majority of cases, there's no cause that we can identify. So the more tests we order, including food skin or blood testing, foods are commonly suspected, rarely confirmed as the cause in patients with hives longer than 6 weeks duration. So there is a harm that we're doing to patients by labeling them inappropriately. Not infrequently, laboratory tests which are abnormal lead to more testing or referrals to other specialists, and there's harm done to patients in association with this. And again, what we want to do is, from a big picture standpoint, is we want to identify diagnostic and therapeutic interventions that are associated with improved patient care outcomes and encourage healthcare providers to do those or do those more frequently, and identify those that are not associated with improved healthcare outcomes and or may be associated with harm, and get the message out that those should not be done as frequently as they're being done now.
And the beauty of this, from our specialty society's perspective, we've been developing guidelines or parameters. Several of us sit on the committees for several years, and it's allowed us to really hone in and talk about the evidence of doing a test or an intervention. I mean, I think choosing wisely brings to the forefront the fact that doing a test or giving a therapy doesn't mean it's good unless it has impact that's useful in the end. And the beauty of this whole dialogue is that we're really questioning what we do and demanding more rigor to prove that it's needed.
I would also want to point out another example. Don't routinely avoid influenza and egg allergic. You'd have to calculate the cost of the non-immunized child of the getting ill, the cost to the system of not being immunized, which could be very costly if it requires a hospitalization. So some of these cost calculations are the comorbid events that occur because a certain procedure or test wasn't done.
Not to be foodophobic, but philic rather, I should say. There's data from our own society showing that children that are labeled with food allergies tend to be bullied more. They tend to have impediment of quality of life. So the downstream effects from these diagnoses can really be quite overwhelming in some occasions.
And what I'll add in is your question addressed economic, and we've given you lots of reasons. We didn't actually look at money, and that's not what choosing wisely is about. Okay, the New England Journal had a editorial in January of this year that suggests extending choosing wisely to look at more economic issues, and you might look there to see what they had to say about that.
Any other questions?
Yes.
I think it's a very good list from Switzerland. So I would be interested. Would you say it would be the same in Europe? I mean, we also talk with people from Europe if we can compare it. That's the first question. And the second question, you talked about the evidence. Would we have a list with all the evidence, or is it accessible for us, this list? And I would be interested when you have the evidence, for example, that some many children died of the wrong therapy with antihistamine. It would be interesting, after having this list now for 1 year, 2 years, if less children would die after that. I mean, would you do this kind of research?
Each of these things, which is just a bullet point for people to glance at, has a fleshed out version with the references, and it is based for the most part on published guidelines which have the evidence. The sinusitis antibiotics is based on the ENT published guidelines, which is all the listed evidence.
Okay, so we will find it online on this list.
Yes, it's all
can
part
I
of it. Yes.
ask Sheila, where did they get the fleshed out version of each of the 5 things?
They're supposed to be available on
the
Tuesday.
ABIM
There
website.
should be somewhere that the
Okay,
sources are
so each one of these has a full page with the references.
And then the second question of the research, if those data would change after a while, I mean, would you follow the research, do some studies?
But much of this is, retrospective. It's not like a prospective study. So looking at the numbers will be difficult. But our hope is it would change behaviors. And the real hope is that this will be promulgated in medical schools and residencies.
Yes. But we would have to follow if it really changes or not. In other words, you do all this effort, and of course, in the long run, we want to know if things really change.
And I don't know that anyone's actually has a research protocol looking at these things, but clearly there would be evidence in the future to show us whether things were working. If we have fewer cases of influenza because everyone gets their vaccine and fewer deaths, then we've had an impact. But are we measuring this specific thing as the only cause of that impact? That would be a hard thing to
But there are no research groups like following all these 10 points?
Not at this point.
Not at this point.
That we're aware of.
And to your question about it being the same in Europe, I don't know if we would have the same problems in Europe. I suspect we do. And do you guys have any?
As I run through the list here, I think that the messages would probably be appropriate elsewhere outside the United States, as well as within the North.
From globalization, when people can order all these tests online, for example, the IgE, IgG tests. I mean, in our pharmacies, you can order the test from everywhere. So
There were both hands up.
I mean, the purpose of this is not necessarily to track the costs, although that's a valid point, but rather to get out key messages and to spark conversations between patients and healthcare providers regarding these issues.
And then, you both had your hand up, and we got to let you both
Larry
speak.
Harrison with Medscape. I was wondering if you see this as an ongoing process where you might have 5 more items every couple of years? And if so, if you feel there's any risk of losing impact and drifting away from the issue of cost control to just promulgating guidelines, which is something that medical organizations have always done.
Well, suppose we pick practical things. When you look at this list, these are not pie in the sky or academic endeavors. These are things that go on every day that have downstream negative sequela. So I would suggest that as evidence continues to be amassed, these may be changed. What we say today may not be true tomorrow. So I'm hopeful that we'll continue to survey the evidence and provide good recommendations to people outside of our specialty and within to do a better job in the various diseases we care for.
I will point out that these are the 5 that made the cut. There were things underlined. So there were other ideas that were limited to 5. But I think we'll probably continue to do this. But again, it's not about the cost. It's about the appropriateness of the things we're doing and reevaluating and evaluating.
Jean-Claude Lemaire from France. First of all, I am pretty sure that all of this is also valid for Europe.
Glad to hear it.
My question is about how timely to ask for the test, because from the radio contrast for the vaccination, for the prescription of antibiotic, it's not at the moment, but the people is there because she has an angina or she will have an examination to do. It's not really the real good time to discuss, but don't worry, we will not have any reaction with the contrast, or we will not have any problem with the antibiotic I will give you. Are you sure that the doctors will take the lead that it's true?
Well, both the antibiotic and the radiocontrast, you can have a dialogue with a patient when they're healthy. What a great time to deal with it. You know, when you're healthy, you say you're penicillin allergic, I really would like you to see somebody and determine whether you are. And the radiocontrast material, you know, you can have that dialogue saying, yeah, I know you're shellfish allergic, and not to worry when you get this radiocontrast material. There's not an association. Would you agree?
But
Yes.
you can have it. You can have the conversation acutely as well. Just as
Yes.
it doesn't matter what time. You can have this conversation at any time during their routine care or acutely, and that's that's the point of this. It's supposed to generate discussion between the patient and the physician. So if the physician goes to do something and the patient says, I read something about that, I want to talk about it more, they'll ask questions, and then the dialogue will happen.
And I'll be honest, this helps the conversation. For me to pull this out and give it to the patient, that's a patient-friendly. It's a complicated conversation for a lay person, so it really helps me to have a face sheet, a piece of paper for them to kind of review and digest. It gives them a little bit more comfort that this was coming from an organization that gave a lot of thought.
Yeah, I was just going to, if I may, just follow up. The issue of the shellfish allergy in particular actually is not something that causes problems, but can smooth out a situation, particularly in the acute setting, where somebody who has a label of shellfish allergy may be regarded as someone who's inappropriately, somebody who's at elevated risk from a contrast procedure, and there may be a reluctance to administer contrast acutely, where based on the messages that we're sending out here, this could allay those inappropriate concerns. And healthcare providers could say, well, because of the shellfish allergy, really we don't have to regard you as being at elevated risk for receiving the contrast procedure. And since you're not at elevated risk compared with the general population, we can go ahead with whatever we need to do.
For this one, I agree, because we are sure that. We are not sure that people saying that he is allergic to penicillin is or is not. So
that has to be
I think with
evaluated.
it's the same. I think what I've just described is the scenario with seafood allergy carries over, for instance, to the influenza vaccination in egg allergic individuals. You should not be regarded as being at elevated risk based on the evidence that Dr. Freeman presented in terms of our experience with administering influenza vaccination to egg allergic individuals. So it's the same thing. So I mean, I think it doesn't. necessarily set up a roadblock. In fact, it alleviates the roadblock.
Correct. And the penicillin, people are often seen for other reasons in the doctor's office, and they have this penicillin allergy living on their chart for years and years. So, when they're healthy, nice to have a dialogue, send them off and resolve the problem. There's nothing more enjoyable for me as a clinician. Yes. Yes.
You had a question.
Yes, from Helio.com. What are the challenges for clinicians to implement these? What do you think are the greatest challenges that we face, day-to-day allergist clinicians on implementing these in practice?
It's not hard because we're doing it. What we are dealing with is people come in with mindsets. Oh no, I'm shrimp allergic. I can't have contrast dye. I've had people specifically sent for consultation for that because they had to have some sort of procedure. Entire consultation of which we take a detailed history, spend their time, their money, etc., and tell them you really didn't need to even see me. But the doctor that referred wasn't comfortable. They weren't comfortable. So maybe I won't even have to see patients like that. But when I have to talk to a patient about this allergy testing that didn't really test allergies and their condition isn't driven by allergies, it helps me explain it to them.
So the biggest roadblock that I see is actually disseminating this out to the people and the physicians, and have them review it and know it so that it's there for use. Okay. So the more people, the more information we get out, the better off we are. That's the biggest roadblock in getting these things done. If you do them, it really simplifies things. People don't have to write consults. People don't have to avoid foods that they're not allergic to. People don't have to get influenza because they got vaccinated. All those things happen, and it's all simpler, not more complex, providing people know about it.
And you, the press, help us also, because part of it is sending this information to the public. Because an educated patient is really the biggest advocate for good health care, are they not? They have to be their own advocates.
We have time for one more question.
In terms of electronic health records, are there any of these tests that you think would be particular, an electronic health record and the expansion of that would be particularly useful in getting an unnecessary practice out of the mix or reduced?
Well, the electronic medical record lends itself well to this in terms of clinical decision support and providing prompts in the electronic medical record which can contain this kind of information.
A good example, sinusitis, where it looks to see how long have you been ill to reach criteria before you reach for antibiotics or a CAT scan.
And then just routinely reminds you to immunize your patients with influenza. Do you have ability to did they get the influenza? If not, why not?
Or did they get spirometry if they're asthmatic?
You're prescribing blank inhaler. Did you do spirometry?
Mm-hmm. And lastly, walking around with a diagnosis of penicillin allergy. Did you really confirm that you're penicillin allergic, as an example?
You're ordering this high-level antibiotic.
Why not?
Why not? Or they have penicillin allergy in the chart. You order high-level antibiotic. Did you assess whether they truly are?
So I think we agree EHR would be a wonderful tool to disseminate this information.
All right, that's all the time we have. Thank you very much for attending.
I appreciate everything. And the press has been very valuable, at least with our first campaign, and getting the message out. It went to very Vogue, and that was helpful, again, in our conversations with patients.
Yeah, it's very cool.
And I encourage you to track down that Less is More article. David Houston's the lead author, Huston.